Good afternoon. Thank you for joining us. Can everybody hear me? Yes. Okay. I hope you all enjoyed your lunch. We appreciate you for sticking around until the end. My name is Pamela. I am the policy coordinator here at P2PH. This will be the third and final panel of the day. The three main areas of focus for this panel will be promising community-based programs that address persistent health needs and prevent criminal legal system involvement, policy and legislative priorities for local officials to overcome barriers to healthcare access, and pathways to build required capacity and expertise to provide comprehensive services to those impacted by the criminal legal system. There will be a Q&A at the end of the panel. Please submit your questions via the QR code on the back of the booklet, or if you're joining us online through the link provided. Today's panel, we have Pamela from Coordinated Behavioral Care, Toya Parker from Institute for Community Living, Stephen Hernandez from St. Anne's Corner Harm Reduction, and Dr. Romo from Hospitals. This panel focuses on the intersection of community health, wellness, and crime prevention. Can each of you briefly introduce yourself and describe your organization's work and how it addresses the overlap between healthcare and criminal justice enforcement?
Good afternoon. A pleasure to be here this afternoon after lunch. I know you said this is the last, but outside of all of the amazing presentations this morning, the best is the last. Anyway, just a little joke to start us off. I actually, before I just talk a little bit about coordinated behavioral care, I really do want to thank John Jay, my colleagues, and also the way that the event was kicked off this morning by Dr. Wright. I think you challenged us so well to sit here in our humanity and shift from thinking about the other to sort of ourselves in community together. And so I really appreciate your comments this morning to set the stage so well for us. Coordinated behavioral care is a behavioral health network of over 75 organizations in New York City that are providing behavioral health, primary care, housing, and social care. Each of the organizations are their own independent nonprofits, but we come together with a collective mission and voice to help impact population health outcomes, as well as create more health and wellness on an individual level. It's really quite a privilege to be able to lead the network. My career has been more in independent organizations. And so to come and work with 70 organizations, sometimes it's a little bit like herding cats so that we all go in the same direction. But even that work in of itself is so critical to help find mission-aligned actions. You'll hear a little bit later about a particular program that we have been working on called Safe Options Support. So I'll leave that for the presentation a bit later, and then leave time for my colleagues to introduce themselves.
Hi, my name is Toya Parker. I work for ICL. I'm working on multi-agency initiative with Pamela, John Jay, ICL, and Brownsville Hospital. We conduct something called the situation table, which is a rapid triage model that addresses risk factors in and around Brownsville. Our original catchment area was Brownsville, but the need was so great, and we can't turn a family down in crisis, so we've extended our catchment area. We sit at a table bi-weekly and talk about families that are in crisis or about to go into crisis, and we sit at a table with about 40 community-based and state and local agencies, and we triage the cases to bring services to stabilize their homes.
Good afternoon, everyone. Stephen Hernandez with St. Anne's Corner Harm Reduction in the South Bronx. We are the oldest continuously running syringe exchange in the United States, which we're very proud of. We were founded back in 1990. Our founder, Joyce Rivera, was part of the original harm reduction working group, which really brought harm reduction for the first time to the States in a response to the HIV/AIDS epidemic. And since that time, we've grown into a mid-sized community-based organization with over 65 employees. We have medical services on staff. We have doctors, nurses, PAs. We have a full-time acupuncturist. We do massage, cupping, aromatherapy. We have a drop-in space. We have a soup kitchen. We have shower services, a clothing closet. We try to do it all. But we're very proud of the work that we do, and those wraparound services are just so crucial for folks, and a safety net really in our society, to offer people options, which is something that you don't get, and really trying to empower folks on the ground in the Bronx, where you have the highest, the worst things is the highest in the Bronx, right? So we're really trying to combat that and push against stigma. And we have touch points in every zip code in the Bronx, except for City Island. But I always joke one day we'll get a boat. So we'll get there.
Hi, hello. Good afternoon. My name is Dr. Noah Romo. I'm a pediatric hospitalist and director of the Pediatric Inpatient Service over at New York City Health and Hospitals, Jacobi. And for the past 10 years, I've also functioned as medical director for our hospital-based violence intervention program there, called Stand Up to Violence. And most recently, I'm also medical director of New York State's efforts to expand hospital-based violence intervention programming throughout the state through the Department of Criminal Justice Services. In the last 10 years, I've worked at Jacobi, and I was able to help establish our hospital-based violence intervention program, which is essentially a hospital-based approach to treat victims of violent trauma in a comprehensive way, and in the sense that we're not just treating their physical wounds, but also trying to address the underlying factors that led to their victimization. Through the utilization of community outreach workers, I work in the hospital alongside myself as a physician and a network of social workers who also help support these patients, not just while they're admitted, but also after their discharge, to connect them to supportive services to help prevent them from becoming just as impacted at being re-injured or being re-involved in some of the circumstances that may have led to their initial victimization. In addition to that, we also have a community network of community outreach workers and supervisors that are individuals from the community who were previously involved in violence, who can now act as mentors to young men and women out in the community before they are injured, and trying to get to them to mediate active disputes, whether they be between rival groups and rival neighborhoods, or whether they be individual disputes, try to prevent retaliation and re-injury in the community to help prevent those patients from ever even coming to our hospital. So it is essentially a comprehensive prevention approach where we try to prevent patients from ever coming in, but also treating patients once they are in the hospital to prevent them from coming back. We have been successful in our approach in reducing rates of recidivism, reducing rates of re-injury, and improving rates of follow-up, and decreasing the rates of community gunshot wounds by 54% in the areas that we are present in. We are in the Bronx, which is a borough of New York City, as was mentioned before, with the highest rates of children and people living below the federal poverty line and the highest rates of violent trauma in the city. Our hospital alone accounts for 25% of all pediatric gunshot wounds in all of New York City. Wow. So we see about 25% of all children under 18 years of age that are shot in the city. So we are disproportionately affected by this, and we have been successful in trying to address some of these complex issues using a comprehensive multidisciplinary approach.
Thank you. Thank you all for your introductions and for the special work that each of you do. My first question is going to Pam. Coordinated behavioral care is a key player in providing integrated care to vulnerable populations. What are some of the most successful strategies you've implemented to connect individuals with mental health and substance use services before they become involved in the criminal justice system?
I guess this is where I get to do my PowerPoint. Wow. And my colleagues all said, oh, let's do PowerPoint. And then I put one forward and they all took a step back and PowerPoint. So anyway, so what I'd really love to share with you is about a program called the Safe Options Support Program. And sort of with a tip of the hat also to the key theme that we've been talking about around language and the way that we think about the people that we're working with. I wanted to show this as this is just a really quick little snapshot of the way that people who are typically living in subway or transit hubs who are homeless, who also may or may not have mental health issues. This is how our media presents them. And you see Next Stop Purgatory. And so there's many more pictures in the news. So important, I think, for at least when I was thinking about wanting to talk to you about safe option support is where this comes from, the safe option support. So there's all of this preceding social problem. Way before COVID, way before we all started to get together. This has been going on for decades, and the way that our systems understand and try and help create better social care for people who are living in the community. The idea of homelessness and mental health really got a lot of media attention in the last decade, but even more so in the last couple of years, as you all know. And because of that media attention, there was a lot more governmental spotlight on the issue. And there was at one point when the mayor produced the subway safety plan, and the same week that the governor produced the Safe Option Support Program, which was targeted to helping people who are unhoused, living in transit, to get into housing. And so I think sort of a quick culmination of all of it came together, and the governor and the State Office of Mental Health decided to invest in creating a program that would be different than what we've done before. And I'll come back to that for a second. So you go from this looks really tragic as it is to then this, where there's a public display of investment in wanting to help impact the problem. And I do tip my hat to the governor and the legislatures for stepping up and wanting to invest in a program that could make a difference. So I want to say something also about the use of language and the way that we think about people in this situation. So I have heard for years that people who have chronic homelessness and or mental illness, it takes months and years to engage them because they're so difficult to engage. And it reminds me of many years ago when I heard a master therapist talking about there are no impossible patients. There are only impossible therapists. And so when I have heard over and over again, people who are homeless are so hard to engage, that sounds to me like we're blaming them for their lack of connection as compared to what's the way for us to create meaning for them to want to connect with us. And on that, I stand very proud on what the SOS program has been doing. We really wanted to target several problems. First, we talked about all day how our fragmented systems are creating bottlenecks and barriers. And it also reminded me as I was listening throughout the day that in some ways, hospitalization and incarceration are great symptoms of how our systems are failing people before they have to get to that type of institutionalization. Now, I don't want to throw either of them out, but I think it's important for us to recognize that they serve a different function than the way that we can really pull ourselves together. And you can see here that there are also other very important problems that we wanted to solve. I really appreciate in some of the other panels the importance of having actionable data available so that when we decide to work together, we can do it with some commonality, not just anecdotes. So the other thing that's really important, I'm getting to what safe option support is, the other thing that's really important is a driving value for us around this program is we're trying to shift from just talking about collaboration to something even more. Because sometimes, and I was having a lovely conversation a little bit earlier, sometimes we use words and we don't necessarily have the same definition for it. And I've heard people say, yeah, I'm collaborating with you. And it means like I made a phone call. And that's not collaboration. But it was to, I'm picking on you, Samantha. But it was to Samantha. So important when we're thinking, when CBC is thinking about safe option support and all the work that we're doing, we're really trying to have connections that are transforming the way that we do work together. So the safe option support is a broad, as you see here, broad cross-sector collaboration with a focus on enduring partnerships. And so a lot of what this conference has been bringing together are different entities coming together to truly try and make a positive impact on a problem. SOS itself is a multidisciplinary team. So there are social workers, nurse, case managers, people with lived experience, all working together out in the community, in the subway stations, out at the bus stations. They are mobile in the community, going to places where people are comfortable and engaging and having conversations with them to find out what matters most to them and then help to bring them out of living in a subway and more into a safe, secure, dignified living arrangement. You can see here that there's a lot of intensive, comprehensive care management. There's a lot of crisis intervention. The model itself is built on another program called Critical Time Intervention. You can Google it, and there's all sorts of full information about it. It's time limited, is that people are enrolled in this program for up to 9 to 12 months. And that the focus is really to build the community connection so that it's enduring and lasting for that person way beyond. So the SOS team will continue to work with that person for the 9 to 12 months while they're already engaging in other systems of care. So that's important to have that continuity of relationship. And one thing it's not overt here, but is really important in some of these other guiding principles is the importance, and I know everybody here knows this, the importance of having the people we serve as sitting on this side of the table, not just I get to bring you to an advisory council and you get to tell me like what you're thinking and what some of the barriers are, and then I thank you. And then the rest of us go behind closed doors. This program and the CBC approach with the network is the consumer, the person we serve, has a legitimate right not only to discuss what's working and not working, but to help solve and design the system. And I think that's a very important piece as we're going through this. So when we talk about collaboration and we're thinking about ecosystems of care, the SOS team, just as an example, have very intensive connections with all of these, plus additional partnerships. CBC oversees 12 different teams that are throughout New York City that operate 24/7, 365 days a year. So when I was hearing earlier, what do we do in off hours? We are always on and available because people who are homeless always have need, not necessarily just during business hours. And what you see here in the partnerships is that we are working with all of these groups to identify where's the duplication, where are the gaps, how do we support each other? How do we use what is working and not working to create better systems, not just warm handoffs? And I don't mean to push off a warm handoff, but we're really trying to build a system that changes rather than just deals with individuals. We monitor our performance through multiple indicators, but these are just a few. So we're monitoring encounters, how many people are enrolled, how many people are involuntarily removed through the 958s that the city is very focused on these days. And I can tell you of the 2,000 people that we encountered over the past year, 6 were removed involuntarily. But there's a very big focus on this. And I go back to some of the news and the narrative in the way that we talk about people. We monitor how many people are hospitalized. We certainly work on housing and the housing stability. So here's a little bit of our impact. We have 14 teams. In the past year, they have reached over 2,000 people that are living in transit systems. 6 out of 10 of those people are then enrolled in Medicaid. Super important for them to be able to access healthcare. And you can see of the 2,000 people, of the teams, though, they had interactions, over 40,000 interactions in a year. It's an enormous amount of engagement. And this number 570, I can tell you, is now a couple weeks old. We have reached over 630 people who are permanently housed, who were once living in the transit system. And I think that in of itself says so much about countering the narrative that people who are homeless take years to engage. That in 1 year, almost 600 people were moved from the situation they were living to safe, permanent housing. Just really applaud the work of the teams who are active. Briefly, we produce a monthly data report. This is just one view of 10 different templates that we send to all of our partners, including the governor and the Department of Mental Health. So everybody has this information all the time, which keeps us honest. And I have to say, there are multiple questions that come every day about what does this mean? Can we do better? That means that we never get to sit back and feel that we've accomplished everything we need to, is that we got to keep moving forward. And then in summary, I would say this is a very short list of complex areas that still need our attention in this program. And it has been mentioned before, housing stock and eligibility barriers. It is, I think, profound that in supportive housing, there are over 15 different eligibility criteria that are connected to a different funding opportunity. So why can't it just be you need supportive housing? So I think if we're still trying to work on that, we need policies intended to reduce homelessness, which have to go far upstream at dealing with issues way before someone becomes homeless. And you think about some of the conversation probably next to one of my colleagues about Black maternal mortality. And if we're not good at that, how are we dealing with homelessness? And then we still need to work on partnerships. And the other data interoperability, I think, says a lot for itself. I'll say one thing and then I'll rest my comments and mind. The other thing that's happened in our health system that's really important that we think about in terms of everything that the conference has been focusing on is care management. And so care management was born out of the need for us to be able to navigate an incredibly fragmented and complex system. And so now every program has a care manager. And every program says that their care management is whole person or person-centered. And I just want to make us a little uncomfortable that can't be. Because if I have 10 care managers for all the different programs that I'm in, unless those 10 care managers are talking to each other and have one plan, none of it is person-centered. What it is that I'm responding to 10 different people with 10 different goals and hoping that I can achieve one of those. And this is, I think, a huge issue for our collective system to deal with. If we're going to have care management, then we need to have a unified care management approach to help people feel not so overwhelmed by our overwhelming system. All right, so I hope I provoked something for you guys. I did do a deep dive into the program, but if you're thinking about language and systems and making sure that we have the voice of the person at the table, then perhaps I'll set you up well.
Thank you. My next question is going to be to Dr. Romo. Given the strain on public health systems, particularly in under-resourced communities, how can state and local governments better support healthcare providers to deliver the comprehensive services needed for individuals impacted by violence and the criminal legal system?
Yeah, I think first and foremost, like any profession, I think we got to be humble in our approach. As physicians, that we don't know all the solutions, and that we cannot care for all the complex issues that our patients present with. We can all agree on the fact that whenever a individual is victimized by violent trauma, it's not just as easy as blaming the victim and blaming the individual and saying, well, you must have been doing something wrong, and that's why you got shot or stabbed, right? And I think we need to kind of expand our approach to not just treat the underlying reason why individuals came in, what the medical reason that is, and treating them with our surgical and medical approaches, but preventing those patients from ever coming back and trying to understand the reasons why they were injured and the different circumstances that led to their injury. And I think that entails us as physicians using different methods and different individuals that are from this community that can understand the individuals better than we ever can, to better connect them to services and resources that can prevent their re-injury. And I think that means we have to expand our approach to how we treat victims of violent trauma, and not just treat them, as individuals that perhaps are viewed as deserving of that violent trauma because they were involved in the criminal justice system before, or because they're actively involved in gang activity in the neighborhoods or have been injured before. Because there is a lot of stigma associated with victims of violent trauma, especially when it's disproportionately affected our Black and Hispanic communities, right? And when that happens, I think we have to take a culturally competent-based approach where we utilize individuals from those communities as community outreach workers, hospital responders to better connect with patients as part of the healthcare team, where we're not just tending to the physical wounds, but having individuals talk to these patients to get a better understanding of why they were injured, the circumstances why they were injured, and perhaps be able to mediate the conflicts that led to their injury, along with addressing the underlying issues that may have contributed to their injury, whether it be obtaining a better job, obtaining a better form of housing. I think there are multiple reasons why individuals get injured, and we cannot just blame the victims as to why that happened. And I think, especially when it comes, from my end, when it comes to children, because we live in a country now where firearm-related injuries are the leading cause of death for children in this country. So our children are dying from a very, very preventable cause. And about 85% of those children that die are Black, and about 13% are Hispanic. So the majority of children that die in this country from gun-related injuries are Black or Hispanic children. And that's unfortunately what we see here in New York City, and what we see in the Bronx. And I think that is going to entail us having all hands on deck in terms of how we address this issue. And I think that issue is highlighted when we see young victims of violent trauma. And just to give you a quick anecdote, we recently had an 11-year-old boy who was shot in our hospital. When I went to go visit him, he was under arrest.
Wow.
And he was handcuffed to the bed. And when I asked police officers why, it turns out this individual was accused of murdering a 16-year-old. It really brought to mind what we are doing in this city and in this country, right? If an 11-year-old feels like his only means of conflict resolution is to pick up a gun and shoot somebody else and then get shot himself, it's not that 11-year-old's fault. I think all of us collectively as a society have failed that child.
That's right.
And we all have to look introspectively to see what we all have collectively done wrong or neglected to allow an 11-year-old to not just be shot, but to feel like they felt the need to shoot somebody else. And it's easy to blame the victim, like I said, it's easy to blame the individual, but it's much more deep than that. And I think until we take a comprehensive approach that puts children at the forefront of that, and until we acknowledge that we have a problem in this country with firearm-related injury and children, particularly our Black and Hispanic children that are being taken away from us, I think we're never going to really solve the issue. I think we need to get beyond politics and just focus on the fact that our Black and Hispanic children are dying from firearm-related injury, and we need to address that.
Yes.
My next question is to Stephen. St. Anne's Corner of Harm Reduction is known for its harm reduction model, which emphasizes community-led care. What do you see as the key benefits of harm reduction in preventing criminal justice system involvement, and how can it be explained in other communities?
So a lot of our folks have been, they don't have a very favorable idea of, let's say, the healthcare system, right? They don't want to go to doctors. They are not treated right when they go to doctors. A few years ago, I asked my grandma, when was the last time you went to the doctor? She goes, no, if I go to the doctor, they're going to tell me all these things are wrong with me. And I was like, well, isn't that the point of going to the doctor, so they can tell you all those things? But why does she feel like that, right? Because she feels like the little person when she's in that room. Maybe there isn't language justice for her, where she doesn't understand what the person is really talking about, right? So having that aspect really creates a very chaotic public health scene. So what we try to do is we try to implement ways in, right? Ways that we can engage folks and actually get them invested in a more genuine way. So even our drop-in space, for example, coming to the drop-in space, which that in and of itself is a very radical idea too, right? A place to go, instead of hanging out all day, come to Satcher, hang out, watch some TV. We have a little gym area. We have an internet cafe. You can stay there and you can work on yourself there, right? But we're not, necessarily pushing you in any direction. So if you have a substance use challenge, you don't have to, we're not abstinence-based. No judgment. We just want to keep you safe, right? We don't ask for ID, nothing. You just come right in. Everything is low threshold. Why is that important? Well, because people now, what they're used to is being pushed towards a certain direction and being pigeonholed, right? Or that this is the only option. Right. Giving folks all of these options really allows them to work on themselves and really take care of all the intersectional challenges that they may have going on in their life. So when they come in, they may not want to talk about an HIV test, or they might not be ready for the housing conversation, right? Maybe they just need an ID. Maybe they're hungry, get them a plate of food, right? So getting there, sitting in the drop-in space, building real rapport with staff, some folks may not want to see a doctor, but they might be receptive to our acupuncturist, right? Because there's a cultural aspect there, talking about cultural competency, right? And I love what Pam said too about, hard to reach populations. We would never use that term. These folks are, there's no such like we never have that experience. Oh, it's so hard to find these folks, they're hard to reach. No, that's not the case at all. If you have real organizations that are by the community, for the community, look like the community as well, you could actually offer folks services that they're actually willing to engage in. And that is just, you just, there's no way around that. And I really do appreciate when people come and they get to tour a center like ours, and they get to see and they ask questions. And I've had countless folks from emergency rooms and colleges, and some of the things I say, they're like, wow, their minds are blown. Even in regards to how we reverse overdose and react to an overdose in the agency, our protocol, implementing oxygen, right? A lot of people are like, well, I never thought to implement oxygen. And I'm like, do you know what an overdose is? It's an oxygen, related issue there. So having all of that and having people actually genuinely invested allows them to work on themselves in a more realistic way. And that gets them, slowly but surely to wherever they want to be. And we also need to make sure that we own our wins, which we never do. You always hear, of course, the data is important, and the numbers are going up, whether we're talking about overdose, whether we're talking about HIV as well, those numbers are going up as well. but we really need to own our wins. And the answer is in front of us, not in a way that it's going to be fixed overnight by any means. But the same way we were able to implement, let's say, syringe exchange back in the day to make the AIDS incidence rate for injection drug users from 65% back in 1990 down to less than 3% today. We can do the same thing with the overdose crisis and implement certain practices like overdose prevention centers, expanding harm reduction centers, all these low threshold services that are proven to really engage folks.
So my next question is going to be to Toya. Your work with the Brownsville Safety Alliance involves the situation tables, which bring together various community stakeholders to address pressing health and safety concerns. This model represents a unique program that has weekly collaboration among so many different agencies. What does it take to get people to keep coming back on a weekly basis?
Prayer? No. Honestly, it's the commitment. One thing I do is I go out and find the people that I want to spend safe. I have a conversation with them before inviting them to say, well, I'll let you come. And then after, we have to have a real conversation about what it looks like to be a part of the table. What does it mean to show up for the community? What does it mean? I'm sorry, I called you 4 times today. Here's my 5th call, but this client really needs this, or this participant needs it. I have been very grateful to find a group of people, of 40 that are really committed to the work. They're committed to what we're doing. They're committed to Brownsville, because they also understand that Brownsville is a very unique space. A lot of organizations have come in and said, hey, we're going to do this. We're going to help. And it doesn't happen. So when I engage with families, I'm not even starting at ground zero. I'm starting negative to, because they come in. I've been yelled at. Oh, you say this, and I get it, right? And I'm not offended by it. I leave my ego. I live in the Bronx. I live in the Bronx, and I come up and I show up as my authentic self, and I do get the buy-in from the community. And this allows us to assist and work with them, because I don't come in and say, hey, you're going to do it my way. I'm going to ask you, what do you want? I ask the participants at the table, what are you prepared to do? Right? Because it's not always a good fit. But with this particular population, many of us experience, you have to show up. You have to do what you say you're going to do. And I think that has contributed to the success that we've had in Brownsville. We talked about Dr. Ramos talked about the 11-year-old child. This is not unique. That is, but we've had a 13-year-old girl. She was being sex trafficked to Port Authority, and she would come back to school and recruit her classmates. How do we, interrupt this? How do we interrupt this? So, I went out. I went to her house. I met with her and her parents, and I asked if you had anything in the world you can do, what would it be? And she said, cook. So what did we do? And so she's 12 at the time. And unfortunately in Brownsville, unless you live in NYCHA, there's not a lot of programming for young adults at 12 years old. So the BSA created program. We created a culinary program in the community. Right. So we're showing up, and I think this is where some of our success has come up, because we show up in a real way. It's not, oh, we're going to say we're going to do something. We do it, and we're making sure, hey, you said you wanted this, you better come out and get it. So I think that's my.
I have another question for Dr. Romo. As given the growing recognition of the need for trauma-informed care, how can hospitals and healthcare providers better integrate violence prevention and mental health support into their services for individuals impacted by the criminal legal system?
I think there needs to be a collective investment, city, statewide, and countrywide. Again, like I mentioned, of how we view violent trauma and engaging patients by investing in programming that is more community-based and that incorporates community members in a comprehensive way, in a culturally competent way. Like I mentioned prior, the mistake we often make in the public health sector is thinking that we can come in and tell communities how they should be healed or treated without incorporating their input and incorporating community members into that same space to help communities heal themselves. And what we've been able to do with our program is hire community outreach workers from the community who were previously involved in community violence or violent trauma. And now we hire them to mentor individuals in the community who are at risk, in particular youth, because of their own lived experience, to be able to get them out of that space and connect them to more positive ways of engaging themselves. And it's these same individuals that we hire with that lived experience that come to the hospital to mentor patients during that critical time period when they're injured, when they're perhaps sitting in their hospital bed thinking about retaliation or reentry, thinking about the individual that just shot them or stabbed them, and they're a little bit more open to hearing alternatives to conflict mediation, where perhaps they won't retaliate, perhaps they're open to an alternative way of living their current life that's going to prevent them from either getting injured again or being killed or are becoming more impacted by the criminal justice system. And I think we need to support this type of programming. Like in our program, we started back in 2014. We had a budget of about $350,000, only funded by New York State Department of Criminal Justice. Since then, now our budget is now $7 million from New York State and also from New York City and also from the federal government. There's some funds that have been allocated to us because of the success that we have had. We've engaged over 3,000 victims of violent trauma in the last 10 years. We've decreased the rate of reentry by 54% in those patients. We provided linkage to job training services to about 65% of those patients, about 20% we helped with housing relocation and education services as well. At the community level, we're in the 43rd, 47th, 49th precincts, and we've decreased the incidence of community gunshot wounds by 54% in those communities. And just this past summer, from July to August, we had 0 shootings in our community target areas in the Bronx, which had not happened in over 20 years. And that type of success is important. And I think it's critical because when you look at the impact of a single murder in a community, it costs each community about $3 million. And that cost comes not just from the individual that is lost, but from businesses that leave, from dropping real estate prices, and most importantly, the cost of the individual not being able to now work and provide for his own family. That's a measure that like you cannot even fathom what that number is. But it's critical for us to take a preventative approach. I think often in this country, not just when it comes to firearm injury, but disease in general, we take a reactive approach where we treat patients after the fact, as opposed to preventing things. And I think what we need to focus on is how do we prevent young men and women from being ever shot, from being ever stabbed, from being involved in this type of community violence. I always tell people my goal in life is to not have to do this programming anymore. For there to be no more community violence to the point where it's like we don't need this programming anymore. It shouldn't be funded. Like I tell all of our outreach workers now, which we have 50 now in the community, is as long as there's a single shooting in our areas and a single victim coming into our hospital, our work is not done. Even if they're just one a year, we still have work to do. Because I think the time has come for us to end the community violence that ravages our communities.
Yeah.
I just have one more question, then we'll move to Q&A because I have a lot of questions for you guys. To Stephen, you provide outreach to some of the most vulnerable populations in New York. What do you think are the critical areas for investment and support that would enable organizations like yours to scale up their services and impact in other parts of the city?
I have a lot of answers for this, but I'll keep it very short. Well, when it comes to harm reduction programs, there's some operational things that is not often talked about. For example, the fact that most of the SSPs or the syringe service providers, harm reduction centers, a lot of us rent. We would love to see a big investment in public health to allow programs like ours to be able to buy a building. I think that would send a really strong message in the investment in the future of public health. I think also there are aspects of workforce development that we would love to see funded. It's very difficult to hire staff who can do the very tough work that we do, meeting with folks, combating that turnover rate. Our linkage list is very much a living document because there are many times where, okay, we had that person, we were able to do warm handoffs, oh, they left. And we find out now, right? So that's constant work. That's very taxing for folks. We still interview let's say nurses who say, "Oh, I've never heard of harm reduction before," or they'll say, "Oh, yes, I know harm reduction, like suicide prevention, right?" And we're like, "No, that's so." The fact that that still hasn't broken that barrier, we would love to see a lot of change there as well. And then I had already mentioned centers like overdose prevention centers can really, again, not a cure-all, but it could absolutely move us in a good direction as far as public health is concerned. And it does address a lot of the public outcry that you hear. So when you see these news packets on, 125th Street or the bid in the South Bronx, in a way, by 149th Street, in a way, we are absolutely aligned with the people who don't want to see people out in the street using substances out in public. Okay, us too. We're not using very stigmatizing language like you are, but we are aligned. We also want to get these people off the streets. We want to get them a safe space to use. We want to get them access to services, engaged, part of the actual society, right? We have a civics initiative as well, where we get everybody at the agency registered to vote who walks through the door. To give you an idea, we see about 250 people a day. That's how many hot meals we do a day out of our soup kitchen. So that kind of tells you how many people we see. All those folks are registered to vote. When electeds come to Satcher, these are constituents. These are not fringe members of your society that you don't really have to think about. You need to think about these folks because they have the ability to be engaged. So seeing investment in all of those realms can really elevate public health. Again, not a cure-all, but we absolutely have the answer in front of us. It's just a matter of how we actually can scale that up.
Thank you. So we'll move to Q&A. This question, anybody can answer. It's not directed towards anybody specifically. How do we build advocacy within our own neighborhoods when stigma perpetuates anger? Can you suggest tangible options on coalition build?
That's a good question. What I've done, essentially what I've learned over the 2 years that I've been doing this work, everyone seems to work in silos. That's the community members, that's the organizations. It is really just kind of getting traction and doing more coordinated work. For me, although we're, hosting a table, a big part of what I'm doing for this year too is more coordinated efforts. We are in a effort with Black Veterans for Social Justice who are working on the PAC program in NYCHA, which is there, some of you may know NYCHA, some of it's being privatized. What that means for the residents is that the apartments are being renovated. So now we're faced with families that people have forgotten about. I met a woman who has a mobile concern. She's not able to walk on her own, but she lives on the 3rd floor. She has not been connected to care in over a year. Her vision is poor, but these are our forgotten community members. So I have found in the community, it is definitely building with other partners, people with like minds, people with the same vision, and really doing the work.
Yeah, I'd like to add to that because my assumption is that the work you're doing and then some of the work that we're doing is leaning into when people are angry. So it's not scary if someone's angry. It doesn't cause us to walk away. It causes us to get our feet on the ground and say, let me hear what the anger is. And then it's easier to get to the next step, whatever the next step is. But I think in a lot of the work that we've talked about today, the narratives push us out into our own comfort zone, and then we don't really get to co-create new models because we're scared of what the other person is saying. So my guess is all of us are leaning into, if you're angry, I'm here, I see you, I hear you, and talk to me.
Yes.
Yeah, and I think it's also important to have trainings and conflict mediation type trainings for our collective staff and different type of advocacy and intervention efforts so that we're all on the same page. I mean, we do statewide training for all of our community outreach workers, our social workers, even our physicians involved, so that we're all trained of how to actively engage in individuals when they are angry, when they are in that space of thinking about doing something or being actively engaged. And I think it's important to work across the spectrum, like we mentioned, and engage like different levels of our society that can help. And like you mentioned, oftentimes we work in silos, and I think we need to understand that like everything in this world is going to take a village, right? And we can't continue to work in silos, not understanding that there are other people trying to do similar work and working in parallel with each other as opposed to intersecting. And I think we need to be better at intersecting.
Thank you. For the next question, anybody can answer as well. How do you reintegrate a person in society who has never been integrated?
Actually, I love the question, and I'm gonna push us to think that the way it's been framed, as if the person never had any social interaction to build on. And so I think what all of us are talking about is, first, we come from a strengths perspective, that people bring rich experience. And so when we're wanting, what the SOS teams are doing is looking for that pearl of where is your strength, what matters to you, how do I help you sort of illuminate that so we can get to the next step. Reintegration is another big word that when we unbundle it means many different things. And I think if we take it a step at a time, then the journey might end up in a more meaningfully engaged in my community. But reintegration for me, whether I'm coming out of any type of institution or out of the subway, reintegration might mean that I get to go home and sleep in my own bed and cook my own meal, and I feel like I'm a responsible community member. So it's sort of the same, continuing to challenge ourselves about how we talk about these issues. I really appreciate that question.
And I'll just add too, it's a matter of really creating these environments in which people can come together. So at our center, for example, we have every day a woman's hour, right? Where you can come and just chat, no expectations. You utilize that time however you want. There are days where they're in there and they just, play board games. There are days where they're in there where they're talking politics. It can go either way. We even have an all women's outreach crew that goes out to help our sex workers out in the South Bronx, right? That kind of community building too. Those conversations that these folks may not feel comfortable having these conversations with most entities, with most doctors, right? So we can kind of be those glue people to connect them and do those warm handoffs and build that trust and really channel the real want for people to better themselves, whatever that may look like. Even with that civics initiative, I mean, we have a lot of, particularly young men who just don't feel like they have any type of power, Black and brown men. And by explaining to them and getting them invested in their community, explaining to them why it matters that they should vote or why it matters that they should go to these community board meetings, because a lot of these meetings, not just the community board meetings, but, the topics that are coming up do affect us all. You may not realize it. It may sound like, nothing ever gets done, right? That's what they want you to believe. That's what we tell them. That's what they want you to have, that opinion, so that you say, I'm not even going to interact with the system because it's not built for me, right? But that's how change really happens. So creating those spaces where people can come together is crucial to make that happen.
Yeah, I think also you mentioned the word reintegration, but I think it really is integration, right? Because reintegration suggests that individuals were never truly a part of society, and they always have been. Perhaps they have been ignored, perhaps they have been under-resourced, but they always were part of our society. And I think at the core of all of this is seeing the humanity in everyone, regardless of what it is they're doing or engaging in, regardless of what their behavior is in, or regardless of what their current situation is in. I see patients. The range is from 10 months to 80 years old as individuals that get injured, shot, or stabbed. And no matter how old these men are, specifically, the reaction is always the same. People think there's these individuals in the community who are hardened, who are involved in violent crime, and they're all tearful. when they're injured. They all ask for one thing. They all ask for their mother, no matter what their age is, right? Because no matter how old we are, we always want our mother by our side, right? When we're injured and when we're in a vulnerable state. And that doesn't change. And I think regardless of the circumstances, regardless of what anybody's involved in, whether they're homeless or whether they're involved in like in drug abuse or whether they're shot, it's all the same. There are human beings there. And as long as we keep that core, like in all that we do, I think we can find creative solutions to any problem.
I think for me, how I look at this, it's more of respecting where the person is. I know you guys talked a lot about the Bronx. I used to work in the living room, and anyone who has context with the living room, it's literally a drop-in center. And you know, a lot of times the clients had substance, and you know, I know harm reduction, and sometimes that is the answer. It's really respecting where a person is, giving them the autonomy to make a choice that we may not deem is, you know, okay, well, that's not the best thing they should be doing at that time, because we give them a space to arrive there on their own, right? So for me in Brownsville specifically, I start with building trust. And I have a very interesting thing that happened to me. A client, I had just engaged with her, and she said, well, what happens if I call you on the weekend? I said, I'm gonna answer. True to form, she called me Saturday and I answered, you know, so it was like we've been able to have some great work done. She was really ambivalent, but it's the trust and respect of what her goals were. How did she get her and her family's life back on track? So I think trust and autonomy is the big one.
Thank you. The next question, I think the first part is for Dr. Romo, and then the second part anybody can answer. How do we obtain data on gun violence and youth from New York City Health and Hospitals? And what strategies do you propose to reduce the gun violence from a public health model?
So the data that we use, the patient perspective is, thankfully we're in the hospital, so we're able to collect all the data. And it's not just gunshot wounds, it's gunshot wounds, stab wounds, and assault, because violent trauma is on the spectrum. What we understand is if you come in with a physical assault, you're 2 times more likely to come in with a stab wound, and then 3 times more likely to come in with a gunshot wound within 6 months. So it's all about intervening early on with the individuals that are involved early to prevent them from getting involved later on. At the community level, our data comes from shooting data from the NYPD as well. They do provide us with notifications on when there are shootings in our target areas for us to be able to analyze that data. And we are working to kind of analyze the data. We've been able to publish in the medical literature on our outcomes. We've been able to kind of bring an evidence-based approach to the interventions that we are engaging in, both in the community and at the hospital level. We were able to publish the first ever article in the pediatric literature about using a hospital-based violence intervention program to decrease the incidence of gunshot wounds, re-injury, retaliation, and improve follow-up for our patients. That had never been done before. And I think it's important from the public health perspective to be able to legitimize these types of interventions and to have the evidence, because I think that is key. I mean, interventions are great, but if you don't have the evidence to prove the effect, it's really hard to continue to get funding for these interventions and to try to also kind of expand your programming to not just the neighborhood that you are in, but citywide, statewide, and national level, because the communities that we are serving are not existing in silos. These communities are all over the country, and these problems are all over the country. And, you know, and I think that New York City is a microcosm of what's going on in the rest of the country. And I think if we're able to do it here, I think we could do it anywhere. And I think we need to have the evidence to prove that our interventions are working. I know we work with Congresswoman Alexandra Ocasio-Cortez, and she provides some funding to us. And I've met with her a couple of times. And the first time I met with her, she said something that stuck with me when she said, look, we're asking you guys to have interventions and programs that work without giving you funding for it. And we're asking you to give us evidence that this works. And then once it works, once you prove that it works, then we'll give you funding for it, which is an impossible task to do. But once you do it, because out of your own efforts with minimal resources, they say, hey, this works, great. Now we'll give you funding for it, right? It is a backwards model because we should be investing in people that are motivated with good ideas to engage in interventions. But unfortunately, is what we have. And in order to do that, we have to unfortunately have the evidence and publish to be able to legitimize our work.
Anybody else? And then I have one for Pam. Could you give examples or describe in detail what co-development of solutions with clients looks like at CBC?
Sure. So when we have been working on the SOS model, there's a couple of different layers that happen. One, I think I just want to start with when we were talking about the model, the agencies that deploy the teams are at the table. And so we're all sort of debating what's the correct way to move this forward. Once we got sort of our feet underneath us, then the next layer is, well, let's invite people who are homeless, who will be served by the model. Let's talk to them. Like, does this make sense to you? How should we reorganize the service? So that was in the beginning. What we do now is both group meetings where we're asking, how do we improve? How does this feel to you? What isn't working? We also do a survey. If survey is too formal, a conversation with a person, does it, like, on a 3-month basis, how is it working? What should we do different? Are we serving you? So it's sort of like a customer service conversation, and all of that information comes back to the table. And then there are people who we're serving at that table. We say, okay, here's the collective. How should we move forward? So it's a real discipline to make sure that it's not unidirectional. It's not like I get your information, I figure it out, and then I do something magical behind closed doors, and then I do something out in the community. It's everything that we hear. You're at the table with us, and then we go try it out, and then you tell us how it's working. So I'm sure the people who lead the meetings will only would have some really good examples. I apologize for not having some specifics. Yeah, so it's not here.
The next question, I'll probably do this as the last question. Given the depth and need, have any of your organizations considered building more capacity with the opportunities under the 115 waiver?
That's such a big question. So I will say this. I think it is bold on the part of the federal government and the state government to identify that social care needs, which is the most important piece in the waiver right now, has been elevated to be part of the conversation. What worries me is the way that we're approaching doing this, and it connects to a lot of the things I think all of us have been talking about, which is standing up a new system in which social care needs are identified and delivered that isn't necessarily integrated from the start with all the other services. And so on one hand, thank goodness we're finally dignifying that social care is really part of healthcare. On the other hand, we're back with the problem of creating more complexity in a system that's already complex. And so, must be an answer coming from my phone. If we take in everything that we've heard today, and including our comments here, I think the call to action around the 1115 waiver around gun control is we have to come to the table with open hearts, open minds, not protecting our turf, and find a better way to prevent people from entering the criminal justice system, prevent people from being shot, prevent people from being homeless. And even if we get to do it for a small handful, I think like you were saying, Doctor, even if it's only like 5 or 10 people, and we prove the concept, then we can market it to others. So I love that we have an 1115 waiver. It's a great experiment. I'm rooting for it because it will make a difference. And I'm also concerned about the complexity it's introducing.
Yeah, I mean, I think I agree with you. I think the 1115 waiver has a lot of potential. But I agree with you. I think it's a little concerning and I have my reservations about it. It's funny because we're all up here doing this incredible work in local communities and having a local impact on individuals and communities, right? And I'm often asked when I give presentations around the country around our programming, if you had a magic wand to end community violence in this country, what would it be, right? And typically people expect me to say, well, we need better gun control law, we need to get rid of this, get rid of that, and my answer is always the same. I say, get rid of poverty, right? If we address poverty in this country the same way we address other issues, and we have the means to do it, a lot, if not a majority of the problems we are addressing here locally would disappear. Right? I'm not saying that is the only solution, but it is part of the solution. There's a root cause to a lot of the problems that we are trying to address. And we are trying to put band-aids on downstream effects and not necessarily addressing the upstream effects, right? But nobody wants to talk about the upstream effects, which is poverty. And if we are able to address that, that I think would have a larger effect than a 115 waiver or anything else the federal government does. If we would just acknowledge that piece, I think it would have a broader impact.
I'm going to squeeze in one last question. I just in from Dr. Romo. What can I do today that's tangible as a community member today?
Wow, another heavy loaded question. I think I would just say to see the potential in every single individual for good. Because I think that if we just did that, I think we would view everyone differently, regardless of their circumstances, regardless of the behavior that they're engaging in. And I think we've lost that a little bit in this country, in the state, and in the city. We become so immune to a lot of the things that we see and that we do that it just becomes normalized, right? Whether it be the person we step over, on the subway who clearly has some drug abuse issues or who is mentally unwell, or the individual who just assaulted that we just walk the other way because we're like, well, it's not our business, right? We become so immune to a lot of these issues that we just kind of live with it and keep walking, right? Without recognizing the impact that it has on all of us collectively. And I think if we just saw humanity in every single person and understood that on any given day, that could be us, depending on the circumstances in our lives or the unfortunate circumstances that unravel. I think that's the best thing we could do, and doing what we can locally as individuals with other people in our communities, and then engaging individuals and communities in ways that can be applied elsewhere so that we're not just having an impact locally, but hopefully state and nationally.
Thank you. We're going to wrap it up now. I think you guys had some great questions from the audience. Thank you all for coming. Special thank you to our panelists today.
I just want to briefly close us out with a few acknowledgments. We've had such a rich, meaningful conversation today, and I really want to once again acknowledge all the panelists who put in time and effort and planning and thought into presenting today, but also for the daily work that they do in community to expand access for people who are already in vulnerable positions. And I know that the work you all do is not always seen by us. But I'm so grateful for you all and everyone who's been able to participate. I just want to leave you all a few very short takeaways because we've had such rich conversations, and I think you all just summed up the day very well. But I'm going home with lots of great just framing and messaging and ways to think about these issues. Like there was a lot of we talked about, instead of reentry, how about reintegration, looking at a person from like a whole person perspective, and what does it mean for them to be well? What does it mean to be a whole and complete community member for them? The other one was what's instead of asking what's wrong with you, but what happened to you, right? That was like from Dr. Wright's comments earlier today. Another one was buy-in versus investing. Like, I don't need you to just sign on to the idea, but what are you going to do to consider future impact, right? Not for today, but in the months and years and decades to come. Needs versus priorities, right? And all of this is going back to that people-centered approach that has come up so many times today. Another one that I liked from this panel was impossible people versus impossible therapists, right? Like, are you the problem or am I the problem? And also hard to reach populations versus offering low threshold services, right? Like, there's so many. I just want to thank every one of our speakers, because I think not only did you present substantive, helpful information, but gave us tools and ways to talk about this stuff going into the future. So thank you to the panelists. We can give them one more round of applause then, as well as everyone participating in today's program. Thank you to all the attendees who bear with us today. I think this is this is such an impressive showing from the audience who's here in person. And thank you. I think this got much helped, and I'm so glad you stuck it out with us. Then also for the folks who were able to join us online and actually stuck with us throughout the day or tuned in for where they can, we're so grateful for you giving your time and attention. And I have to thank folks like Sarah Monahan at the Data Collaborative for Justice that does an amazing job of coordinating the event. Tiffany Sloan, who moderated the second panel. Samantha Bella, who from Punishment to Public Health, who have been an incredible team and have put in so many incredible working hours and dedication to make sure that this program was beneficial to all of you. So thank you. I hope we can continue to have these meaningful conversations at John Jay College. We're so glad to be partnered with From Punishment to Public Health and the greater John Jay community. So thank you so much.
Thank you.